Welcome to Health IT Matters, a podcast in which we explore the ways health information technology is transforming healthcare locally in Florida and on a national level. I'm your host, Chris Wilkie. In our last episode, we heard about the wide range of health IT solutions the Agency for Healthcare Administration is making available to patients and providers throughout the state of Florida. Continuing our podcast series for National Health IT Week, we're going to share some individual experiences with health IT, starting with a healthcare provider. Dr. Phillip Smith is a board-certified family physician with a subspecialty in Clinical Informatics. He is also a healthcare IT consultant and the founder of MedMorph, LLC, a company that helps healthcare providers solve the toughest health IT challenges. Dr. Smith is also the author of several books, including Making Computerized Provider Order Entry Work and MedRec, Proposing a Solution for the Nightmare of Medication Reconciliation. With 40 years of healthcare experience, Dr. Smith has seen the evolution of technology in the healthcare arena since its onset. In this episode, Pam King, the Health IT Outreach Coordinator for AHCA, sits down with Dr. Smith to talk about the challenges and solutions health information technology has presented over the years and what we have to look forward to in the future. And with that, here's Pam King and Dr. Phil Smith.
Chris, today I am really excited that we have Dr. Phillip Smith, who has done, I think, everything in the healthcare arena that you can do. He has been a physician assistant. He's a physician. He has been in IT, has looked at things. He has implemented an EHR system into his private practice, as well as looked at the national level of security that we need around health IT. And so it's really exciting to have you with us here today, Dr. Smith, and sharing with us some of your knowledge and years of experience. We won't say how many years. Well, we can. I'll let you share how many years of experience, but you have had a lot of years of experience and have looked at health IT from kind of the initial inception of it until today. And so I'm really excited for you to be able to share with us some of the historical knowledge you have around health IT.
Well, thanks, Pam. And yes, I have the gray hair to show it. I've been in healthcare for 40 years, started as a surgical PA and then went straight into med school, where I actually did an MS-MD degree, which was kind of interesting. That's a story for another day. And actually did my first informatics practice in residency when I realized that we were not optimal on how we were aligning the clinics that we did in our family practice residency to make sure that we optimize the specialty clinics such as dermatology and orthopedics, that we actually optimize the opportunity to attend all the clinics and not conflict with our family practice clinics. So I worked with a computer scientist back in 1985, and we wrote a totally macro-driven program based on Lotus 1-2-3, if anyone can remember the predecessor to Excel. And we built this whole system of rotation-based scheduling to optimize every family practice resident and his or her clinics so that we could both be in our family practice clinics and yet take full exposure to the available clinics in the subspecialty areas that we were in. So my informatics career actually began a long time ago. And I went into my family practice and was one of those people that hung a shingle back in 1987 in Florida, in Newport Richey. Started out as a single physician practice and realized that back in the 1980s, we had about 40,000 drug-drug interactions, and I decided I wasn't smart enough to keep those in my head. And so I went out and started looking for tools to help me practice better medicine. Seems to make sense. And I found a program that had been written by a family physician out in Iowa. It was called Escalapian Concepts. It unfortunately doesn't exist anymore. And I automated my medical practice, bought that program in 92, implemented in 93. And I believe I was the first physician in Tampa Bay to have a fully functional electronic medical record. And it totally changed the whole dynamic of my practice. It was unbelievable. The system paid for itself in 9 months. I actually brought home $40,000 more that year in profit, which was a huge amount back in the early 1990s. And actually saved about 2 to 3 hours per day in my practice because it became so efficient. So I got everything I wanted out of it: efficiency, effectiveness, and better cash flow, and found a way to use the data from the EMR to actually optimize my whole patient flow so that I could create bandwidth for patients to be able to walk in any day of the week, Monday through Friday, for walk-in appointments and be able to accommodate them and not get behind in the schedule. So it was amazing. Patient satisfaction went through the roof. And in Florida, as many doctors know, we have a lot of snowbirds. And so the only time I would print my records was I would print today what we call a clinical summary. And I would literally print out a summary plus the office visits of all my patients who are going north for the summer, and they would hand carry their records. So I was doing the equivalent of open notes back in 93 when I didn't even have my first internet connection till 95. So I didn't have an email account till 95. And if anybody remembers, I was running on IBM 386 computers, and I remember how big those were. And I redesigned the office, and I had a computer in every room. This was long before laptops and microcomputers and all the things, tablets and all the things we had today. And believe it or not, I included the patients in the experience. And I only had, out of 10,000 patients in the practice, I only had one patient leave because they were scared about having the computer in the exam room. And I made sure that the computer did not interfere with the physician-patient relationship by making sure I did my normal workflow. And then I said, okay, I want you to wait, and I'm going to go ahead and do your note because I may have some additional questions. And what I would do is, while I was in the exam room, I would do the note at the end of the visit, and I'd always make sure I asked one or two other questions to clarify something I wanted and capture it immediately in the electronic medical record. And by the time the patient left the room, I was done with my note. They would go up and check out. Any prescriptions they needed were actually printed and legible, including all the typical side effects that were on a little tear off on the side of the prescriptions. The pharmacists began referring me patients because they said they could read the prescriptions. And I began getting doctors in Michigan and Ohio and New Jersey and New York referring me patients because they were so pleased that they could actually see and read my records that they had. I eliminated transcription costs completely. And all my notes were done, which meant the next day, my nurse would call anyone who was on a new medicine or was a first-time patient or had come in for a walk-in patient. Kathy would call them between 8 and 9 in the morning. This was before cell phones. And we would follow up with them proactively to find out how they were doing, were they having any problems. And patients thought I was lying awake all night worrying about them. And for us, we could call them proactively. We didn't play telephone by handing off the call to 3 people in the office. And we were proactively. And my nurse actually had the completed note in front of her at the moment of she was talking to the patient. And she could update a phone call with the person. And we just found that the office ran more efficiently. We saw more patients. And it lowered our overhead. So what was not to like about that? And I think we lowered risk as well. So So that was my experience with my electronic medical record. And meanwhile, in 95, I practiced at an HCA hospital, and we had 10 HCA hospitals in Tampa Bay. So they asked me to serve as kind of the chair of the physician engagement committee for the effort. So I got my first taste of clinical information systems on the hospital level in 95 with Meditech. And then I ended up by 95 deciding I wanted to go into informatics. I sold my practice, stayed on board for a couple years to transition, eventually ended up spent a couple years with Cerner Corporation as a physician consultant back in the days when EMRs were really departmental specialty apps. And I began working on enterprise solutions where we were actually automating hospitals. And over the last 26 years of automating hospitals, I've actually automated, I believe, 65 at this time. So children's hospitals, academic centers, community hospitals, and Moffitt Cancer Center in Tampa. So I've pretty much implemented hospitals in, I believe, over 30 states, a lot in Florida, and have got some of the first HIMSS level 7 hospitals in the nation, and all of them had very high levels of adoption. So I've been in the industry a long time, written a couple books, one on CPOE, one on medication reconciliation. I'm serving on as one of the private partners with the Department of Health and Human Services, which we issued best practices last year for cybersecurity practices in healthcare. And I continue on that in that position as both a contributor and author. And I'm also working with the state of Connecticut, looking at revamping medication management in that state and eliminating the inefficiencies of medication reconciliation and all the technical and source of truth problems we have in that. So, yeah, I've been doing a lot of crazy things over the last 40 years.
I don't know about crazy. It's very innovative, especially for when you began working with IT and integrating that in with healthcare. And bringing it back to, you talked about the utilization and how you took a look at tools that were available to help you as a physician. There are a lot of physicians today that are just now implementing EHR systems. And so what are some of the ways that they can probably better utilize health IT tools to help them with their practice?
Yeah, that's a great question, Pam. And I think we have kind of a perfect storm that was set up by the whole meaningful use program, where electronic medical records were really pushed onto the industry with economic incentives and made sense for hospitals and health systems. And when I was at the time the chief medical information officer for the Adventist Health System, which is now Advent Health, and we had a multi-state hospital system, and we already had the meaningful use pathway in place because we were already doing it. One of the things I've always done is used a lot of change management methodologies to prepare people and help them to understand the value that they would have. So as I said earlier, I wanted the EMR to make my life and my patients' care better. And so I was looking at what data can I get out of it to improve office efficiency? What can I do to help my patients have better access to the care? What can I do to improve my practice profitability so that I can invest in better serving my patients? What can I do to improve communication with other doctors? And so when you approach it that way, and many doctors would approach it that way, yet they didn't really have the time no one was selling the value of what is in it for me. And so we ended up pushing the EMR out to so many people before we really prepared the industry to be welcome to it and to see the value of what it could provide for them. So it's really unfortunate, the unintended consequences. And then the other factor was this work is really hard. And I've always said, if you automate one hospital, you've automated one hospital. And having automated over 65 hospitals, or about 1.5% of the hospitals in the US, I realized that every health system, every hospital, every doctor's office is a culture in and of itself. And it just can't be dealt with a cookie cutter rollout. This is what you need, and adopt and adapt or fall behind. You really need to understand how people work, how they think, and what are the value statements for the individual people adopting it, and what can you do. So unfortunately, we had a lot of implementations occurring through a lot of people who were young in their careers, didn't know these things. They just thought it was implementing the technology, not adopting the technology and finding value for all stakeholders: doctors, nurses, hospital administrators, all those people. And myself, having been a hospital administrator for 4 years, having been a medical staff leader, having been a practice owner, having to be a chief medical information officer and an inventor, I realized that I had to help all constituencies succeed. And I think that's what's been missing in the industry. We just don't have enough people stepping back and saying, okay, the electronic record is here to stay. What can I do to make my practice more profitable? What can I do to make my workflow more efficient? What can I do to improve my access for my patients, both to being able to be seen, or virtual visits, or walk-in visits, or phone visits, or follow-up? What are all the things that we could leverage the EMR to do that we could have never done in the paper world with our illegible prescriptions and our notes that were incomplete? And so today we end up with templated notes which have just terrible context to them, too much data that is really geared towards billing and not really about the care of the patient. So we really need to look at how we hold physicians accountable to the documentation of the billing question, and get back to taking care of the patients, which is what every doctor in the country goes into medical school to do, which is to be an excellent provider of excellent care. And we've kind of stepped in the middle of that and derailed a lot of the political capital through the pushing out implementations with inexperience and without a clear message of what people need to be successful.
Well, I really like the distinction you made there about implementing versus adoption. And we have a lot of physicians now that have implemented EHR systems in their practice, and then hospitals throughout their systems, versus actually adopting the technology and looking at how they can use it to provide that better health care. And so, and you mentioned a lot of the challenges. So do you have advice on how to overcome some of these challenges now that the horse is out of the barn, so to speak? What are some things that we can do to overcome some of the challenges that are out there right now?
Well, I would say that in the last couple of years, there has been an opportunity to align payment incentives through the MIPS program, which has allowed people to do innovative projects where they improve access, improve patient care. And I would encourage physicians to see their EMR as a great place to do a MIPS program to take some aspect of patient care. So accessibility for walk-in visits, patient-centered medical homes, patient education, after-hours access, open notes, being able to share what you're putting in the record with your patients so they can see them. So there's a lot of innovation that's available. In fact, I wrote a 12-part blog series a couple years ago on ways to step-by-step do 12 months of projects to help people and optimize basically their EMR. But it all starts with actually taking that leap of faith and moving your mindset away from being the victim of your EMR to being someone who has an electronic health record, and you're committed as a physician, as a physician assistant or nurse practitioner, as an office nurse, how am I going to leverage this investment in technology and move beyond victim into adoption and optimization of my practice, not only for my personal benefit, but for the benefit and welfare of my patients, my staff, and the productivity and profitability of my medical practice. So it really starts with making a decision. And then there's lots of resources out there that you can access for free to find ideas and share ideas with other people. I've done this over and over for the last 40 years and found lots of people who have made that transition from being the victim of their electronic health record to being the master. But it starts with making a decision.
Very insightful and good advice to share with our listeners today. I want to close out today with just your thoughts on the future of health IT. I mean, you've seen a lot. You've seen basically the beginnings of information technology merge with healthcare. And so what are your thoughts about the future? Where do you think we're going? What are you excited about for the future?
Yeah, I guess I'm most excited about redefining the health system as a patient-centered, patient-empowered health system, and to get away from the traditional insurance model, a bit more into the innovative model. We're a great economy to experiment. And unfortunately, we've had a lot of government payment programs that have been put into place very fast. And we've done a lot of reacting to the payment models rather than innovating to how can we give better care. And we're starting to see it in the retail industry as we see organizations like Walmart and Walgreens and CVS and places like that offering consumer-driven care models using virtual visits and video visits and telehealth and remote patient monitoring and all these things tied to artificial intelligence that will help to look at trends. And I think ultimately we will succeed when we move from a model where the patient becomes the reactive person to the payment models to being the empowered person that has a vested interest to manage their care and to find people to match that model and empower them. And it started with kind of the concierge model a few years ago, which is the beginnings of that, but I think needs to be extended to where we have to, I think just like doctors are victims of their EHR, I think sometimes patients feel like they're the victims are at the beck and call of their insurance payers, because we all fear getting in the hospital and having these huge hospital bills. But what we should be demanding is that our non-hospital care, and I call that the non-catastrophic care, that the day-to-day preventive care, that we're more empowered and educated to know what we need, to have more transparency of pricing, to have more accessibility to innovative models that would help us to do it. And I think we're making a mistake moving away from trying to commoditize care delivery and put it into lower areas. I see that in pharmacies trying to make clinical decisions. I would say that I really don't want a pharmacist just because they understand medications. I don't think they're trained in the pathophysiology of disease and wellness. So I think rather than making pharmacists care delivery people, we need to better leverage them in the medication management sphere. And we need to free up physicians and physician extenders to provide innovative models to provide care through virtualization, through accessibility, and then empower patients to be more actively engaged in their care. And I think price transparency is a big part of this. I can't believe any industry in a laissez-faire economy like ours, where you go into some place and you get a care done and you don't know what it cost until 6 weeks to 6 months later when someone sends you a bill. And now you get a bill from 20 different people, from pathologists to radiologists to anesthesiologists, from the health system, the primary care doctor, from everybody. And it's just totally confusing. And I mean, I would never go shop for a new car and drive it off the lot and then have the car dealer start billing me separate for the tires and the brakes and everything that I needed to be successful. It's just so against how our economy actually works. So it was, I used to laugh back in the 1990s. The big thing was, well, we need to engineer healthcare. Well, that's nonsense. Healthcare was never engineered to begin with. It's a cottage industry. We still think it's a cottage industry. And we need to unleash the innovation, which is starting to happen with some of these retail organizations. And as we unleash the innovation, we're going to see great strides in how we can deliver care. But healthcare at the end of the day is practiced locally. And it's the relationship between the patient and the people taking care of it. And we need to meet the patients where they're at, get more resource availability, and make it less complicated and less expensive.
As always, anytime I hear you speak, anytime I talk to you, I'm always feel in awe and well-informed and invigorated. I'm ready to unleash the innovation. And I hope those of you that were listening to the podcast are ready to unleash your innovation as well and move towards a healthcare system that embraces all of the wonderful things that Dr. Smith shared with us today. Dr. Smith, I can't thank you enough for being with us and sharing your thoughts and your wealth of knowledge with all of us today.
Well, I thank you, Pam, for the opportunity, and I hope the listeners get value out of this, and I look forward to all of this coming to fruition over the next few years as we embrace innovation and come up with practical solutions to meet the needs of our free market economy.
That concludes our interview with Dr. Smith. As you heard, health information technology is not always easy to adopt, but when it's done right, the benefits are innumerable. I'd like to thank Pam King, Dr. Smith, and everyone listening today for joining us. In our next episode celebrating National Health IT Week, we will dig a little deeper into how health IT is shaping the individual experiences of those who come in contact with it with a personal perspective from a patient. Remember, you can stay up to date with podcast episodes and all other agency-related news through our social media pages on Twitter @ACA_Florida, on Facebook @Florida Agency for Healthcare Administration, and on LinkedIn. Till next time, this is Chris Wilkie for Health IT Matters. Here's to your health.